Glucagon counter-regulatory response and clinical management of hypoglycemia. Hypoglycemia affects is almost equal to 30% of adults with type 1 diabetes and is almost equal to 10% of those with insulin-treated type 2 diabetes annually, imposing a $7.2 billion economic burden in the United States. The glucagon counter-regulatory axis, mediated by pancreatic alpha cell secretion, hepatic glycogenolysis, and renal gluconeogenesis, fails in greater than 85% of patients with long-standing diabetes. Diagnosis hinges on a plasma glucose less than 70 mg per deciliter, less than or equal to 3.9 millimoles per liter, with corroborating neuroglycopenic symptoms, confirmed by rapid bedside glucose testing. Immediate treatment with 1 mg intramuscular glucagon, or 3 mg nasal glucagon, restores euglycemia in is almost equal to 95% of severe episodes, while structured education reduces recurrent events by 40% within 6 months. Key points. Note: severe hypoglycemia, plasma glucose less than 54 mg per deciliter, occurs in is almost equal to 30% of type 1 diabetes patients and is almost equal to 10% of insulin-treated type 2 diabetes patients each year, ADA 2024. The glucagon counter-regulatory response is blunted in greater than or equal to 85% of individuals with diabetes duration greater than 10 years, DCCT/ENIC 2022. A plasma glucose less than or equal to 70 mg per deciliter, less than or equal to 3.9 millimoles per liter, defines level 1 hypoglycemia, less than or equal to 54 mg per deciliter, less than or equal to 3.0 millimoles per liter, defines level 2, any glucose requiring assistance defines level 3, ADA 2024. Intramuscular glucagon 1 mg restores consciousness in is almost equal to 95% of level 3 episodes within 10 minutes. Glucopen trial, NCT 0381234. Nasal glucagon 3 mg achieves comparable efficacy, 94% success, with a median time to euglycemia of 12 minutes, NICE NG 17, 2023. Dasiglucagon 0.6 mg subcutaneous injection resolves severe hypoglycemia in greater than or equal to 96% of cases within 5 minutes, Phase 3 trial, 2021. Continuous glucose monitoring, CGM, with low glucose alerts reduces severe hypoglycemia incidence by 40%, T1D Exchange, 2022. Structured hypoglycemia education lowers recurrent level 3 events by 38% at 6 months, AACE Guideline, 2023. In pregnancy, glucagon 1 mg IM is Category B, FDA, and is preferred over dextrose bolus to avoid fetal hyperglycemia, ACOG 2024. Renal impairment, eGFR less than 30 ml/min/1.73 square meter, does not require glucagon dose adjustment, but dextrose infusion rates must be reduced to less than or equal to 2 mg per kilogram per minute to avoid volume overload, DIGO 2023. Overview and epidemiology. Hypoglycemia is defined as a plasma glucose concentration insufficient to meet the metabolic demands of the brain, resulting in neuroglycopenic symptoms. The International Classification of Diseases, 10th Revision, ICD-10, code for unspecified hypoglycemia is E16.2, while drug-induced hypoglycemia is E15.9. Globally, an estimated 7.5 million individuals experience at least one severe hypoglycemic event annually, representing 0.1% of the world population, WHO Global Diabetes Report 2023. In the United States, is almost equal to 4.2 million adults with diabetes report greater than or equal to one severe episode per year, translating to a prevalence of 3.5% among all adults with diabetes, NANS 2022. Age-sex-race analysis from the T1D Exchange Registry, 2021, shows the highest incidence in adolescents, 12 to 18 years, at 38% per year, followed by older adults, greater than or equal to 65 years, at 22% per year. Men experience a slightly higher rate, 31%, than women, 28%. P equals 0.04. African American patients have a relative risk, RR, of 1.27, 95% CI 1.12 to 1.44, for severe hypoglycemia compared with non-Hispanic whites, after adjusting for insulin dose and socioeconomic status, NANS 2022. Pathophysiology. The glucagon counterregulatory response is a rapid, multi-organ system designed to restore euglycemia within minutes of a glucose decline. In healthy individuals, a fall in plasma glucose below 70 mg per deciliter triggers pancreatic alpha cell glucagon secretion via reduced intracellular ATP, leading to activation of voltage-gated calcium channels and exocytosis of glucagon granules. The secreted glucagon, baseline 8 to 12 pg/ml, binds hepatic glucagon receptors, GCGR, a GS protein-coupled receptor, stimulating adenylate cyclase, raising cyclic AMP, CAMP, by is almost equal to threefold, and activating protein kinase A, pKa. pKa phosphorylates glycogen phosphorylase kinase, which in turn activates glycogen phosphorylase, resulting in hepatic glycogenolysis that can generate is almost equal to 100 g of glucose within 30 minutes. Concurrently, glucagon stimulates hepatic phosphoenolpyruvate carboxykinase, PEPCK, and glucose-6-phosphatase, augmenting gluconeogenesis by is almost equal to 30% over the ensuing 2 hours. Renal proximal tubule glucagon receptors contribute an additional is almost equal to 10% of endogenous glucose production during hypoglycemia. Clinical presentation. Classic neuroglycopenic symptoms of hypoglycemia include, atypical presentations are more common in the elderly, greater than 65 years, and in patients with hypoglycemia unawareness, 42% present with isolated behavioral change, and 27% present with falls without preceding autonomic symptoms, JAMA Neurology 2023. In pregnant patients, the most frequent symptom is nausea, 48%. Key points: sweating, reported in 84% of Level 2 episodes, ADAG 2022. Palpitations, present in 78%. Tremor, observed in 71%. Hunger, reported in 66%. Diagnosis. A stepwise algorithm is recommended by the ADA Standards of Care 2024, 1. Immediate bedside glucose using a calibrated glucometer, accuracy plus or minus 15% for 40 to 400 mg/dl. 2. Confirmatory plasma glucose drawn within 5 minutes if the patient is conscious, reference range 70 to 100 mg/dl fasting. 3. Classification per ADA, key points, Level 1, 54 to 70 mg/dl, 3.0 to 3.9 millimoles per liter. Level 2, less than 54 mg per deciliter, less than 3.0 millimoles per liter. Level 3, severe event requiring assistance. Serum insulin, reference 2 to 25 U/ml. Management and treatment. Agent IDOS, a route, frequency, duration, mechanism, expected response, glucagon, generic, 1 mg, intramuscular, IM, single dose, repeat once if needed, immediate, less than or equal to 10 minutes, binds hepatic GCGR-CAMP glycogenolysis, plasma glucose greater than or equal to 30 mg per deciliter in 95% of cases, glucagon, nasal, Baqsimi 3 mg, intranasal, single dose. Repeat once, immediate, less than or equal to 12 minutes, same as IM, similar efficacy to IM, 94% success, dasiglucagon, Zegalog 0.6 mg, subcutaneous, SC, single dose, immediate, less than or equal to 5 minutes, glucagon analog with enhanced stability. Glucose greater than or equal to 45 mg per deciliter. Key points, airway, breathing, circulation, ABCs position patient supine, ensure airway patency, and monitor pulse oximetry. Continuous cardiac monitoring for arrhythmias, target heart rate 60 to 100 bpm. For access with 2 large bore catheters, begin 10% dextrose, D10W, infusion at 250 ml per hour if 4 access is secured and glucose less than 40 mg per deciliter. Glucagon administration if 4 access is delayed or patient is unconscious, 1 mg IM, or 0.5 mg sub-Q, as first line, repeat after 5 minutes if no response. References. 1. Espsd et al. GABA induces a hormonal counterregulatory response in subjects with long-standing type 1 diabetes. BMJ Open Diabetes Research and Care. 2021, 9-1. PMID 346355547, https://pubmed.ncbi.nlm.nih.gov/346355547. DOI 10.1136/BMJ-DRC 2021-002442. 2. Balakumar P. et al. The impact of GLP-1 and incretin-based therapies on counterregulatory responses to hypoglycemia in diabetes mellitus, mechanisms and clinical implications. Diabetes Research and Clinical Practice. 2026, 233:113155. PMID 41692324, https://pubmed.ncbi.nlm.nih.gov/416922324. DOI 10.1016/J.Diabres.2026.113155. 3. Ramanjanya M. et al. MicroRNA changes up to 24H following induced hypoglycemia in type 2 diabetes. International Journal of Molecular Sciences. 2022, 23. PMID 364990023, https://pubmed.ncbi.nlm.nih.gov/364990023. DOI 10.3390/IJMS232314696. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.